photograph now all the speakers one so that yeah.
Well, Dr. Bamrah, I hope you don't have any objection to a part of it being recorded.
No,
not at all.
Not at all.
Right.
Well, good evening, everyone, and welcome to this important seminar of the Bombay Psychiatric Society on Borderline Personality Disorder. I'm Dr. Avinash D'Souza here, the president of the society, along with Dr. Priyanka, the secretary, and our entire executive committee that welcomes you to this event. It's one of the few large, big events on borderline personality that we've been having this year. It's a very common condition, and we're having different aspects to it. We have something on the diagnostic end, something on the pharmacological management, and we have something on the non-pharmacological or the psychotherapeutic management. So we have a plethora of three great speakers here today evening. Before I introduce Dr. Bamrah, Dr. Mittal sir, my co-chairperson and the president of the Indian Association of Private Psychiatry, who has, I mean, it's an Indian Association of Private Psychiatry program where we have teamed up with Bombay Psychiatric Society, and I'm lucky enough to be the secretary of the Indian Association of Private Psychiatry while being the president of Bombay Psychiatric Society. So that's how this is merged. So Dr. Mittal sir, your comments before I introduce Dr. Bamrah.
Well, let me clarify. You're not lucky, you're deserving. That's why you're in the post. It's not by luck that you get these posts. Yeah, welcome all on behalf of the Indian Association of Private Psychiatry. Why this topic? Most of us in private practice, this is one clientele group that we all find very difficult to deal. As this program develops, I hope what my intention was becomes clear, that as Dr. Bamrah will put it, cross-culturally and across continents, across castes, across religions, across races, across socio-economic status, the presentations do not vary much. Their nature, the basic nature of the presentations remain the same. And for us clinicians in different settings, we are all busy, and especially private psychiatrists. I'm especially talking about private psychiatry. You know, you are different if you're in NIMHANS or AIMS or a government institution where you have 20 psychiatrists and a lot of time to deal with these patients. In private psychiatry, everything has to be a quick fix. This is the population of patients who require a lot of care and time, and a lot of professional therapeutic management on an individual basis, on a group basis, on a support group. And we do have somebody who runs support groups on these kind of patients on this program, on this sessions today. So my intention was that if we could introduce this topic in such a way that Dr. Bamrah would talk about his experience with different cultures, and then Dr. Nagpal would talk about specific pharmacological management. And then, of course, Avinash and one of the ladies who runs an NGO, which runs a support group, they would have a discussion about how they manage therapeutic interventions in these patients on an individual support group therapy. That is basically the intention of this whole program, and I'm going to be very happy if we can take home even a couple of ways which are different from what we have been doing in the last few months or last few years of our practice, especially for private practice. So thank you, Avinash, and please go ahead and introduce Dr. Bamrah.
Yes. It's now my proud privilege to introduce Professor Dr. Js Mumrah, who is a psychiatrist, researcher, writer who's been working in the UK for the past 3 decades. Sir has been awarded the CBE by the Queen for his work in mental health, which is the highest award that she can give. And he is uh, one of the few psychiatrists in the UK who is speaking Marquis's Who's Who. So we're very privileged to have you here, Dr. Bamrah. His title of his talk is Borderline Personality Disorder, to Be or Not to Be, a Diagnostic Conundrum. So over to you, sir. You are being made co-host, so you could share your slides and start presenting.
Thank you very much. It's a great privilege to be here. Thank you for your very generous comments, Avinash, and Dr. Mittal. I look forward to seeing you in Chester when you next come here. Now, let me see how I'm going to share my screen. Okay, let's see. Hopefully you can see this. And I might disappear from my own view. So, yes, so what I was going to talk about was you can see. Good.
Yes, sir, we can see.
Okay, let me. Is that better?
You have to go to the slideshow. Yeah. Perfect now. Perfect.
So I thought what I would do is, so let me tell you first thing that I'm not an expert on borderline personalities, no more than any one of you is. One of the problems with personality disorders is that it's a poorly researched area. We've all researched into schizophrenia, borderline bipolar disorders and dementias and all those concrete medical areas. But personality disorders until recently got very little attention other than labeling people as personality disorders. So as a general and old age psychiatrist, my job is to diagnose them as anybody else does and treat them like anybody else does on the best available evidence and literature. It does pose as a diagnostic conundrum though. So let's talk about personality disorders, the whole area of personality disorders first. Now the DSM-5 criteria for these are A, B, and C, an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. So you should have 2 or more of these 4 symptoms: cognition, affectivity, interpersonal functioning, impulse control. And these personality disorders have to be pervasive, they're chronic, and they affect social functioning, work, school, close relationships, because as you're aware, C will tell you that this can be traced back to adolescence and early adulthood. So personality disorders, by the very nature, arise from a very early time in our adolescence or early adulthood, before our personality becomes absolutely formed. Patients develop a disorder. That's why it's a personality disorder. The DSM-5 also gives us 5 diagnostic criteria, of which are antisocial, avoidant, borderline, dependent, histrionic, narcissistic, obsessive compulsive, paranoid, schizoid, and schizotypal. So an estimate for prevalence of personality disorder in the community is around 10%. This rises to 30% if you consider interpersonal difficulties, but they're not quite a disorder, but a bit of a difficulty in particular situations, which a lot of us will have, but that doesn't mean we have a personality disorder. The studies have shown that 24% of patients presenting to primary care, which is in the UK, as Dr. Mittal will know, GPs, 24% of them have personality disorder. And in secondary care, 50% of patients meet the criteria of personality disorder. So much more when it comes to psychiatry or psychiatric services. And even so, these are actually underestimates. Why is that? Well, psychiatrists are reluctant to diagnose personality disorder, partly because we lack the expertise, partly because it's a pejorative term. And the untreatability, or so-called untreatability of it, makes many of us reject them from our services. For many, there's a stigma associated with the diagnosis of personality disorder. But in the last 2 decades, there has been a difference. And that has arisen through the DSM-5, actually. There's been a drive to make personality disorder a diagnosis of inclusion rather than exclusion. There was a major publication by WHO in 1993, and another major publication in the UK by the government of UK through NICE in the 90s that said we need to be less reluctant to make the diagnosis because patients have the right to know, you have the right to know, and then you can tailor the treatment, which I think we'll be talking about afterwards, to that particular disorder. So the topic of my conversation is obviously borderline personality disorders. Borderline personality disorders defined by DSM-5 as a pervasive pattern of instability of interpersonal relationships, self-image, affect, marked impulsivity beginning by early adulthood and present in a variety of contexts, so different places, school, work, family relationships, all that sort of thing. And within that framework, the presence of at least 5 of symptoms I'm going to describe in a minute are considered necessary in order for borderline personality to be diagnosed. And the 5 criteria are abandonment, intense, unstable interpersonal relationships, unstable self-image, sense of self. Impulsivity is a major issue. In fact, almost all the patients I've seen have had impulsivity. Can be very self-damaging. Example, overspending, being over-sexual, substance misuse, reckless driving, binge eating. And you will see in the majority of cases, if not all of them, and that is why they come to our attention usually, recurrent suicidal behavior or threat to harm others. Self-mutilative behavior is pretty common in these patients. And then there is affective instability, which I will be talking about more of, chronic feeling of emptiness, and intense anger and difficulty controlling anger. This is also almost an invariable feature. In fact, I've seen that just in a patient I saw this morning. Exactly this, and self-harming behavior. And finally, paranoid ideation, or loosely speaking, some psychotic symptoms as well. So 5 of 9 of these are criteria by which you would diagnose borderline personalities. But it's not without its controversies. Does it really exist? Is borderline a distinct entity? Well, controversy erupted from DSM-3 in 1979. Central to the discussion of the validity of borderline personalities was the review of Leibowitz in 1979, who stated that when the St. Louis approach, which is a particular diagnostic category, is used for diagnostic validity as a guide, conclusion is reached that available data do not weigh conclusively for or against borderline personality as an independent entity. Seaver and Gunderson the same year had questioned the decision to separate schizotypal personality disorder from borderline personality in DSM-3. There was huge angst and anger, which should not be underestimated. The whole of the academic and clinical world was upside down because borderline personalities were made a separate entity. And also it was argued the justification for this separation is not rested on genetic evidence, but rather on the relative independence of the behavioral characteristics of 2 dimensions, which is schizotypal and borderline personality, both of which are about borderline issues. So schizotypal, as you will recall from your reading of the literature, was about borderline schizophrenia. And that was how schizotypal personality, not quite psychotic, but with some characteristics of schizophrenia, loosely speaking. And borderline personalities was a bit like that, that is in the borders, but not quite defined. While the DSM-3 was trying to get us away from that and trying to put some structure to borderline personalities. And Spitzer et al., who were proponents of borderline personalities, through their research delineated 2 personality disorders the same year. They gave a distinction between schizotypal personality, which, as I said, was associated with schizophrenia, and borderline personality. And they stated very strongly that previously a vague, mythical, and muddled concept achieved significance of other commonly used psychiatric diagnoses through their work, and particularly with the inclusion of DSM-3. They were fervently in favor of borderline personalities being included. They argued that this separation provides the tools for investigators to study the interaction of genetic and environmental factors in borderline personalities. And the benefit of this separation was already apparent because research investigations were now using these terms in different phenomena. Just before that, the ICD-9 had failed to grasp this, even though 25% of UK psychiatrists were diagnosing borderline personality disorder. There's a typo here, apologies, it's not DPD, it's BPD. And borderline personality disorders, they said, represented 15 to 25% of personality disorder in patients, according to this study in 1982. And a review by Tarnopolsky and Belotowicz affirmed the diagnosis and the status of borderline personality disorder. However, Peter Tyrer, who was and still is a prominent and eminent psychiatrist in the UK, he was the editor of the British Journal of Psychiatry at the time. He felt that borderline personalities had a greater affinity to mood than to personality. So there still remains that gray area and controversy, to be truthful, which I will come to in a minute. So borderline personality, what is the prevalence? Well, it's a severe psychiatric disorder which affects about 3% of the adult population. It's very common in young people, as Dr. Mittal was saying. The estimated prevalence in young people is 1 to 3% in the community, 11 to 22% in outpatients, and a third to half of inpatients have the diagnosis of borderline personality. Now, when you look at borderline personality and compare it with other mental disorders, it is among the leading causes of disability-adjusted life years in young people and a leading cause and risk of suicide. 8% of borderline personality, again a typo, beg your pardon, 8% of borderline personalities actually commit suicide. They complete suicide. Borderline personality disorder is also a substantial financial burden for families of young people. And in this USA survey, $15,000 was the cost to the family or the individual, while $45,000 per annum were the cost to the insurance who paid out for that treatment. There is some genetic research on this as well. A recent review concluded by Segal et al. Concluded that evidence for heritability is around 40% in borderline personality disorders. However, the search for genetic candidate gene has not yielded any results at the moment, because according to them and other authors, the tendency is to look for the precise gene when they should be looking at the genetic effects on vulnerability to environmental cause of disease. Now, yeah, so this is the only cultural evidence I have, Dr. Mittal, because there aren't transcultural studies as yet of borderline personality, but right at the bottom column, you will see that in indigenous groups, in this study, they found that 9.5% of indigenous population of a large sample, 948 individuals, had borderline personality. But it seems that in immigrants, it is less so. So only, for instance, 2.9% of Asians who emigrate to the USA have borderline personality. And you could argue that borderline personalities are less likely to be organized enough to travel abroad. Unlike patients with affective disorders, you will find that paranoid and affective disorders tend to have a large cohort of immigrants in them. What about gender differences? There are no real gender differences, but funnily enough, when you compare men with women, well, women outnumber men slightly, but when you compare men with women, men are more likely to be less educated, more likely to be more impulsive and angry, more aggressive, more likely to have comorbid narcissistic, antisocial, paranoid, schizotypal personality disorders, more likely to abuse alcohol and substances of misuse, but they're less likely than women to be dependent or have obsessive compulsive features. Men are more likely to die by suicide than women, while women are more likely to act out and self-harm themselves. Unlike the general population, where women are overrepresented in suicide attempts and borderline personalities, there was no gender difference. Oh, okay. In gender difference, there was no difference in borderline personalities in suicide attempters, whereas in personality disorders as a whole, women are overrepresented, and in neurotic disorders, of course, women are overrepresented. So, beg your pardon, go back to that. There's no gender difference in suicide attempters in borderline personalities. So the key issues you would take with you is borderline personalities struggle to develop and maintain a coherent sense of self. Their thoughts and feelings are frequently very fluid and very unstable. They are volatile in some of their attitudes and commitments. These aspects have been interpreted as disturbances of narrative identity or selfhood. They have great self-doubt. But the core feature of BPD, borderline personality, is affective dysregulation, identity disturbance, and difficulty in social interaction. Abandonment is a very key issue. You look at your patients, even though they are not abandoned, which I will explain to you in a minute, they feel abandoned. And actually, clinical experience suggests that social rejection and solitude can trigger states of aversion, tension in individual or borderline personality. And in this study, at least, they showed that these rejection, solitude precede self-injurious behavior. So they have a sense of rejection and isolation, and then they carry out self-harm. And in this study by Stabler et al., they found that borderline personality patients scored high on questionnaire measuring rejection sensitivity. And you would see that they're a highly sensitive individual. The slightest thing and they feel rejected. And compared with other groups, they reported a greater tendency to both expect and perceive rejection in social. So they go into a social situation thinking, I am going to be rejected by these people. And they will react even more strongly from these experiences than other people will. So other people, where they are or perceived to be rejected, they do not have the same impulsivity. They will guard themselves. They will not respond in the way that borderline personalities do. So social exclusion and abandonment are really key features of borderline personality disorders. One study reported that borderline personality disorders, this is the second bullet point, feel rejected by others, even in situations which they are actually being included and in which social actions cannot be attributed to voluntary decisions of others. It's that sensitivity, hypersensitivity that they had. Being accepted and included might be unexpected for most borderline patients whose self-perception is characterized by negative beliefs of not being likable. They just think that they are not likable. And they have this assumption that other people are not trustworthy. And according to Festinger's theory of cognitive dissonance, this assumes that when people encounter a mismatch between their expectations and actual experiences, they resolve it by changing their perception. They have this expectation and they develop a perception around that, which includes that sense of rejection, that sense of other people are not trustworthy, which produces several domains of dysfunction, affective instability, impulsivity, anger, transient psychotic, and dissociative symptoms, intense, unstable relationships. They go from one relationship to another in a very dysfunctional kind of way, very traumatic sort of, which just increases their sense of isolation and all the other dissonance that Festinger talked about. Borderline personalities often demonstrate high comorbidity and make numerous suicide attempts and parasuicidal gestures, which actually then confer significantly higher risk for completed suicide. 8% of them, as I mentioned, go out and kill themselves. Now, there's a high spectrum of psychiatric disorders associated with borderline personalities. There's compelling evidence of PTSD, ADHD, depression, and bipolarity in these patients. And also borderline personalities commonly experience psychosis, and there appears to be an association not so much with anorexia nervosa as there is to bulimia nervosa in borderline personalities. So a high risk of other psychiatric disorders also occurring in these patients. There's only one study that I could detect which looked at cerebral functions in these patients. In this study of a small sample of 10 borderline personalities, there was a direct cerebral correlate to social inclusion and exclusion. In this study, borderline personalities played a card game with 2 real partners while undergoing functional near-infrared spectroscopy. The card game was adapted from the Sabharwal paradigm. What their findings showed was that there was altered processing in the frontal limbic, where our personality sits, our behavior sits, that there was an altered processing during social rejection. It's only one study, needs to be repeated, but it's quite an interesting thing that they found this in their functional spectroscopy. Now, psychosis in borderline personalities is also a very common occurrence, as you're aware, but it's very uncommonly understood. Particularly auditory verbal hallucinations occur quite commonly in my experience. Auditory hallucinations are often perceived by patients with borderline personality as originating from inside the head, whereas in schizophrenia, usually they come from outside, sometimes from inside, and these are termed as pseudo hallucinations. But nevertheless, they have a detrimental impact on well-being. In fact, patients with pseudo hallucinations quite commonly are very, very disturbed and act out. So auditory hallucinations in borderline personalities are underpinned by aberrant perceptual cognitive mechanisms for signal detection, experienced subjectively as persecutory and distressing, associated with distinct patterns of neural activity that inform proximal mechanistic understanding. Strawson argued that rather like patients with schizophrenia, auditory hallucination experience is significant in borderline personality and must not be dismissed as pseudo hallucinations. Rather, it must be a treatment priority. You have to tackle that more seriously than we do. And what about the commonality with bipolar affective disorder? In many patients, there's an overlap between borderline personality and bipolar affective disorder too. Symptoms like affective instability, impulsivity, disinhibition on antidepressants, genetic loading with bipolarity existing in both sides of the family pattern are quite common actually. It's therefore conceivable that must be a tendency to pay more attention to axis 2 diagnosis rather than to bipolar disorder. So in effect, we tend to, because borderline personalities are more dysfunctional, more disruptive, more dangerous in a way, we tend more to attend to that than to any bipolar elements in their personality, which is something that authors, researchers have criticized clinicians on. It is clear, though, that more systematic research is needed. When the diagnosis is not clear, I don't know if Dr. Nagpal afterwards is going to say this, but There is therapeutic value in treating these patients with mood disorders. And I don't want to dwell too much on this. There's the old psychosis-neurosis dichotomy. Populations research has showed that there is substantial co-variation of mood and psychotic symptoms. There's lots of evidence to show the last bullet point, psychosis, rather than be distinct from neurosis, can in fact reflect important features and inform about neurotic psychopathologies. That is why the distinction of psychosis and neurosis, we still use the psychosis bit, but it is blurred. In most patients, it is blurred. What about psychosis and personality disorders? Existing evidence suggests that personality disorders in psychotic patients is more often diagnosed in research studies rather than in clinical settings, suggesting that certainly in our clinical situations, personality disorders are underdiagnosed in psychotic patients. In one study of 137 patients with schizophrenia, nearly a quarter had coexisting personality disorders. And these were schizoid in 32.6% of patients, schizotypal in 21.7% patients, borderline in 15% of patients. In this group of personality disorders, there was a high risk of substance misuse. Nearly a fifth of them had substance misuse, commonly alcohol. But cannabis abuse as well is very common in this group of patients. There was no significant correlation, interestingly enough, and I didn't know this until I looked at this statistic. No significant correlation between comorbid personality disorders and schizophrenia and duration of hospitalization. So in other words, having a personality disorder did not determine the length of stay. It was schizophrenia that determined the length of stay. Also, rate of rehospitalization during 1 year was not dependent on personality disorder, rather it was dependent on schizophrenia and psychosis. The PAN score on initial assessment was the same, whether a patient had personality disorder coexisting with schizophrenia or schizophrenia on its own. But there was a positive correlation between having a personality disorder as a comorbidity with schizophrenia, interesting enough, improved therapeutic adherence. And there was also a positive correlation with symptom severity at discharge for inpatients. So severity of symptoms of schizophrenia and personality disorder meant that you're more likely to discharge these patients earlier. What about affective disorders? Well, authors have argued that there's a greater affinity to mood than personality disorder in borderline personalities. And therefore, this should be regarded primarily as an affective symptom. So borderline personality overlaps, as you're aware, with other personality disorders, PTSD, anxiety disorders, depression, adjustment disorders, all that sort of thing, as I've mentioned before. But these authors argue that it belongs to none of them. By having a layer upon layer of diagnostic requirements that allow it to become grossly heterogeneous, it has confused everybody and satisfied none. There's good evidence, these authors say, that borderline personality characteristics are closely linked to affective instability, not normal personality variation. And this is true. In natural history, borderline personalities have a good case of remission rather than of persistence. Although in my patient that I will demonstrate in a minute, the opposite is the case. Now, you will remember Wolfman, I hope. This was Freud's most famous case study. And he talked about a privileged man who grew in a Russian aristocracy with interpersonal difficulties right through childhood and adulthood. Bloom suggested that this person had a borderline state on the basis of Kernberg's criteria, whereas on a recent re-examination of the case by Abramson, which was reported in Schizophrenia Bulletin, he made a very compelling case of recurrent affective disorder. Now, lastly, we're near the end of it. Now, borderline personality disorders and older adults, as you would expect, maturation happens in patients as we grow, as they get older, and so personality disorders generally fizzle out. But borderline personalities feature prominently in the increase of risk for suicide in older adults. And where borderline personalities exist in these patients, half of all patients will present with suicidality, indicating an overlap of various personality disorders in older adults. However, now this is an important thing, borderline and histrionic features contributed to an increased fear of suicide and a fear of social disapproval of suicide. So whereas there was increased risk of suicidality and self-harm in older patients with borderline features, the risk of actually killing themselves was reduced if they had borderline personality. Therefore, it would seem that borderline personality is a protective characteristic in older patients with other psychiatric disorders. Now, I'm going to tell you about my patient DC. She first presented to me in 2009. She'd presented with several self-harm attempts. She'd been to the local A&E several times, indeed to such an extent that eventually she was banned because she was swearing, using the F word and saying bastard to brown and black nurses. So the nursing officer decided that despite all these presentations, she was going to ban DC from racial abuse of ethnic staff. DC was a female. She had an average upbringing. She had one older sister. She had one younger brother. She idolized her father and her brother. I'm not going to go into psychotherapy here. She had no known history of sexual abuse. Her first documented onset of personality difficulties was around 18. She enrolled to become a nun because she was dissatisfied with what was going on in life. After 4 years, she was thrown out, which is quite senior in the history of being a nun, actually. She was thrown out by the nun superior, sister superior, because she was a rebel. She was quite often angry, impulsive. She wouldn't make relationships at the nunnery. And so she was, much to the regret of her Catholic parents, thrown out of the nunnery. She got married in secret. Nobody knew about this, not even her sister. Her sister was shocked when I told her that her sister had been married. The marriage only lasted 2 years and did not consummate. She worked as a teacher. She wanted to be a school pupil. She was very anglicized. She wanted to adopt one of the pupils. He was blue-eyed and blonde. He had his parents, but she went out of her way to fight against this boy becoming her own, against all odds, which was quite bizarre because the boy was already with parents. He was well brought up. She had no friends, but in her latter years, she was very close to her sister. I'm sorry about this picture. This is the picture that was recently taken by me. I sectioned her 4 times. She probably took over 1,000 overdoses, and this is an underestimate. In her lifetime, she often drank large amounts of wine, frequently scalded her arms with hot water, and never felt the pain, well into her 80s. This picture was taken in 2017. She would abuse foreigners in public transport and assault passers-by in the local cemetery. She would just do this. She would tell foreigners, you know, people of Asian origin or European origin, that they were fleecing on the state. And she was quite an angry person. I last saw her on 10th of February 2020. She'd taken an overdose of 40 paracetamol over 48 hours. There's no reason for me to send her to casualty because she'd done this so many times. A lesser person would probably be in A&E or intubated because of liver failure, but she'd done this over the years so many times. Eventually, she died a happy death, I have to say. She died of an MI at home on the train, just almost 2 weeks after I saw her. She just died of an MI. I treated her for the duration of a time with fluoxetine and trazodone. So this is the history of my patient DC. So in summary, borderline personality is a distinct entity, I believe, characterized with instability of interpersonal relationships, self-harm, self-image, affective symptoms, marked impulsivity, begins by early childhood, but frequently diagnosis is delayed. Prevalence is up to 3% in the community, a quarter in the outpatients, half of them in your inpatients settings with a borderline personality. It is a common cause of comorbidity with other psychiatric conditions, carries a high risk of suicide. Therefore, early diagnosis, early treatment is important. There's an overlap with psychosis and borderline personality. Sorry, not BAD, but BPD. And therefore, treatment with mood stabilizers and antipsychotics is often recommended. Borderline personalities are a major burden on the individual, families, and society, and must be treated early and effectively with structured psychological and pharmacological treatments. And thank you very much for listening.
Thank you, Dr. Bamrah. I'm sure your case you described in detail is going to be at the higher zenith of most of our clinicians in private practice. Even during our lifetimes, we rarely experience a patient with such a degree of however, it is not uncommon during my stint at the NHS and even subsequently from my colleagues, and we hear from other colleagues that these are not unique number of attempts or number of or the severity of attempts, and the abuse of the NHS system by these patients is rampant, and it is kind of a play for them in a way. I remember when I worked in Liverpool that they would compare the number of stitches each one got for the cuts that they did, and would be unhappy with the resident on call if he'd given them less stitches. I mean, it is as you said rightly, a very complex and a very unresearched field where a lot more needs to be done in the community and in the patients on an individual basis, and that should be helping in both therapy and in terms of pharmacology and the therapy, non-pharmacology. To now talk about the pharmacological therapy, can I invite Dr. Nagpal? Dr. Rajesh Nagpal is ex-president of Indian Association of Private Psychiatry, biological psychiatry. He has been a very active member of the Delhi Psychiatric Society. He's a private practitioner with a very, very busy practice in Delhi. He actually does a lot of work with these kind of patients. What more I can say about him? I mean, he is going to talk about the pharmacological management of the disorder. And Nagpal, you can begin your.
Thank you, Anupam. Thank you. Thank you, Dr. Anupam Mittal. Thank you, Dr. Bamrah, for an excellent erudite presentation. Thank you, Dr. Avira D'Souza, for inviting me.
Thank you, Dr. Avira D'Souza, for inviting me.
Am I audible?
Am I audible?
Your voice is echoing.
Your
voice is echoing.
You have.
So what do I do?
No, it's better now.
Put your phone off. You got two devices on at the same time. Put one of them off.
I'll put it off. Just one second. I don't think it's phone. Phone is not interfering actually. Is my voice okay now?
Yeah, very clear.
Okay. So here we go. Some caveats. Guidelines for the British National Health Service recommend not
National
using
Service
any pharmacological
not
treatment for
using
borderline
any
personality
pharmacological
disorders.
treatment for borderline personality disorder.
The guidelines go so far as to suggest that any existing pharmacotherapy should be carefully tapered off. Drugs like sodium valproate, lithium, or naltrexone on high doses used to treat facets of bipolar disorder like impulsivity and aggression by many among us is not covered. Because I'm only going to cover over borderline personality disorder per se and not the domains. Omega-3 fatty acids can decrease depression, suicidality, and affective instability. However, there is no evidence base in BPD, or is there? That's a question which I'll answer. This is a very ironic situation. I'm a great proponent of pharmacotherapy, but it's one of the few situations where the data on psychotherapy outweighs the data on psychopharmacology. My second caveat is that I am not focusing on affective dysregulation, behavioral discontrol, or cognitive or perceptive symptoms separately, the three domains of borderline, if you might. The adult phenotype of these symptoms, lifelong, highly disabling, and identified in the adolescent, is being discussed only. In the absence of biomarkers, young psychiatrists might challenge how dare I make a diagnosis like say BPD is beyond the scope of this talk. So, this is by Strofer's publication done last year, suggesting that there are very few studies available in the last 5 years on bipolar disorder, on the borderline personality disorder. We can see from 2016 onwards, very few studies available in comparison to the non-borderline personality disorder spectrum. So there is a therapeutic pessimism. Considering the number of randomized controlled trial testing drug treatments for BPD, it becomes clear that drug treatments are being paid less attention to. This observation is in line with recommendations of major clinical guidelines for the BPD, both Australian and NICE, which concordantly would recommend psychotherapy as a first-line treatment. There is some optimism regarding psychotherapy. There is rapidly accumulating evidence of psychotherapy evaluation in studies in borderline personality. Cochrane review included 20 randomized controlled trials, and the 2020 update by Strobo identified 75 such studies. New systemic reviews and meta-analysis support beneficial effects of psychotherapeutic interventions on relevant clinical outcomes, such as psychosocial functioning, BPD severity, or self-harming and suicidal behavior. So very strong data sets in favor of psychotherapy, particularly DBT for BPD. Paradox. Most people with a diagnosis of BPD receive medications of a large variety of substance classes, oftentimes many drugs concurrently. So there has been large series of studies done, 15-year studies, and 2195 patients by Sabharwal et al. 2015. In the absence of psychotherapy, comorbid conditions would require medication. Addition of new substances in times of crisis, which in the absence of regular medication, simply accumulate over time. So most of the medicines added for BPD are in the context of comorbid disorders. Strofer's reviewed the most recent evidence of RCT trials evaluating continued drug treatments in people with a diagnosis of BPD. Focus was on randomized controlled trials of drug treatments for people with borderline personality disorder that reported clinical outcomes. So I'll go through the major classes which have been discussed. As Dr. Bamrah said that he was treating with say fluoxetine, so let's see the evidence for that too. High rates of antidepressant use and startling lack of evidence. The most recent placebo-controlled RCT testing of antidepressant is still the one of Simpson and colleagues, which was with fluoxetine and DBT, published in 2004. Large cohort studies concurrently showed that the antidepressants are the medication class which is most often prescribed with rates ranging between 70 and 80%. Of course, depressive disorders are highly prevalent in BPD, and if a manifest depressive disorder is present, it may require medication. Refer et al. Compared the medication rates of those patients with BPD who had a comorbid depressive disorder to the medication rates of those who did not find a difference in the type and number of medications. So even in those not having depression, antidepressants was being used extensively. Payton and colleagues report antidepressant use in 94% of patients with an emotionally unstable personality disorder who also had comorbid depression, but also in 75% of people who had unstable personality disorder as their sole psychiatric diagnosis. So it appears that even in the absence of depression, antidepressants are the treatment of choice. Almost like antidepressant prescription is by default. Comorbidity does not account for the high use of medication in BPD. There is complete lack of reliable supporting evidence, be it from meta-analytical, accumulated evidence, or at least single RCTs, except the one RCT which I talked about, Simpson 2004. Surprising considering the use of antidepressants. Furthermore, comorbidities like affective, anxiety, or traumatic disorders are common in BPD, and these conditions may warrant medication use, which is in line with recommendation of the major BPD guidelines. Data from clinical practice indicates that drug use is not related to comorbidity. Sorry. So now we should focus on antidepressants. Find there is a very low evidence base to antipsychotics. Neither olanzapine nor asenapine are treatment options. Bozzello and colleagues 4 years ago compared olanzapine and asenapine head to head and observed very limited differences. Remember, these are only RCTs I'm talking about. Olanzapine was superior regarding dissociation, asenapine regarding affective instability. Unfortunately, the trial did not include a placebo control group, so this trial compares two substances of uncertain efficacy. Inconclusive from the evidence that olanzapine was a helpful and safe treatment option, and asenapine has never been subject to a placebo control RCT in BPD so far. Even if asenapine has been found to be conventionally superior to olanzapine, it would be still uncertain if the patient shows profit at all. There is limited therapeutic effect on one hand. On the other hand, the adverse effects for both asenapine, oral hyposthesia, anxiety, restlessness, and akathisia, and for olanzapine, weight gain, somnolence, metabolic syndrome, and fatigue. Sorry. Cotypin is also being used very frequently. There is only one existing placebo-controlled RCT of Cotypin, Black et al. 2014. Observed moderate to large statistically significant effects for both doses of Cotypin, 150 and 300, regarding BPD severity, psychosocial impairment and aggression, and additional effect for the higher dose regarding manic symptoms. Comparing the two active groups, both 150 and 300, there is no superiority of any group. Notably, there is no clear dose-effect relationship for clinical outcomes, that is beneficial effects of treatment, but a higher proportion of participants experienced adverse events in this group with the higher dose. Both doses were associated with a significantly heightened rate of adverse events, most prevalent ones being sedation, mouth dryness, change in appetite, and headache. Very similar to what we found for the Embolden study also for say Cotypin in studies for say bipolar depression, where sedation continues to be a major side effect. Of course, the doses there were almost double. There are contemporary ongoing trials. Two placebo-controlled RCTs are currently underway to evaluate the effects of brexpiprazole, an SGA which has been described as a modulator. Another placebo-controlled RCT is underway in the UK where patients with BPD who did not experience adequate clinical response to antipsychotic will receive clozapine, the CALM study. Another placebo-controlled RCT of aripiprazole for people with a diagnosis of BPD and auditory verbal hallucinations, but without schizophrenia or any psychotic disorder. Notably, this will be one of the first RCTs ever investigating the beneficial and harmful effects of pharmacological treatment in adolescents with BPD, minimum age 15 years, maximum 25 years. Why Cotypin has an outstanding role in BPD treatment? International studies concordantly report antipsychotics being prevalently prescribed to people with diagnosed BPD, with rates ranging between 70 and 79% of inpatients and 35 to 60% of outpatients. Among antipsychotic agents, refer says, Cotypin is the one which is most often prescribed to people with a diagnosed BPD, and above all, it is also the one single substance most often described among all the substance classes. Actually, every fifth to almost one-third inpatient would receive Cotypin. And remember, very little evidence for Cotypin, except one study of black. Mood stabilizer, I'm sorry for the spelling mistake. Lamotrigine. A large RCT study has been conducted by actually Crawford, 2014 and 2018. Two studies were done. They compared the effects of 12 months of lamotrigine treatment to placebo and observed not one significant difference between the two groups. Including a large sample of 276 participants, the study had enough power to detect clinically relevant differences had there been any. So lamotrigine failed in a placebo trial. Other strengths of the study are the long observation period, which was about 35 weeks, and the broad inclusion criteria. Only comorbid bipolar and psychotic disorders were excluded. The authors concluded importantly that lamotrigine is neither a clinically nor a cost-effective treatment option for BPD. Of course, that's in the context of Europe. In of course, India, lamotrigine is of course cheaply available. Weighing uncertain beneficial effects against possible adverse effects, mood stabilizers are not an expedient treatment option in a population of patients, most of which are women in childbearing age. And this is in particular reference to sodium valproate, for which there is no evidence base for BPD. Though we might talk about a lot of experience that we have had with sodium valproate, which will of course come in the discussion. Some exploratory trials. Memantine. Memantine, a substance anti-dementia drug that targets glutamic system, has been tested against placebo. Kulkarni et al. Of course done work abroad 2018. Many people with BPD have chronically been exposed to stress due to maltreatment during childhood. That's the whole theory of the external disorder and the trajectory thereof. Chronic stress can induce changes in glutamate release and glutamate receptor functioning, resulting in overactivity and excitotoxicity. By moderating the glutamate transmission, the memantine may reduce BPD severity and self-harming and impulsive behavior, especially which all have been found to correlate with glutamate concentrations. Very good theoretical aspects. The study authors report a significant higher rate of change of BPD severity by memantine in latent growth analysis, curve analysis. Calculating the SMT from post-treatment data, Stoffers could not replicate a significant effect. Instead, a final BPD severity score was higher in the memantine group. So memantine, in spite of its fancy explanation, doesn't cut much ice in BPD. Mifepristone identified another placebo-controlled RCT without a full text publication, but it's been listed in the clinical trials. In this study, the effect of mifepristone, a glucocorticoid receptor antagonist that is also used as an abortive agent, are tested. Mifepristone is supposed to alter a putative hyperresponsiveness of the HB axis. Calculating between group effects at post-treatment from the posted raw data, we did not find a statistical significant effect favoring mifepristone, but a consistent threat throughout all was reported measures in the placebo group. These findings speak against a possible role of mifepristone in BPD treatment. So that also has failed. N-acetylcysteine, available in the country very easily. A reference relating to a small placebo-controlled study of N-acetylcysteine as an adjunct to an ongoing DBT treatment. However, the posted study results refer to 6 participants, of which 2 completed a 6-week study. The authors state the study was terminated due to poor subject compliance. So even that failed. Some ongoing trials. Ketamine. Ongoing RCT testing the effects of ketamine against a control treatment with the relaxant midazolam. Ketamine has been observed to rapidly reduce suicidality and improve mood in patients with MDD. This is an ongoing study aiming to assess the effects which can be found in a diagnosis of BPD. The second study is botulinum toxin A. The effects of botulinum toxin A, a relaxant that is injected in the forehead, studied in ongoing RCT. Application of botulinum toxin A results in a paralysis of facial muscles that are involved in the expression of negative emotions. Thus, the afferent feedback is interrupted, which putatively alleviates depressive symptoms. Participants allocated to the control condition will receive acupuncture sessions. Outcome assessment include depression and BPD pathology, the outcome is still awaited. Results are still awaited. So the takeaway is no beneficial effects by fluoxetine in the prevention of suicidal behavior in people with BPD, but inferiority to psychotherapy treatment instead merits close attention. SSRI being the most often used substance in BPD, regardless of coexisting comorbidities, it is remarkable there are only 3 placebo-controlled RCTs of SSRI in BPD. One of them was the Simpson study, I said. Second was Salzman, and third was Rene. Total participants were 85 only. So though used very frequently, there is little or no data available for us. Thought-provoking. So I said that Crawford had 2 studies, 14 and 18. Another remarkable new finding is the failure to detect beneficial effects by lamotrigine treatment in a real-world effectiveness study. This large-scale pragmatic RCT yielded conclusive results that applicable routine care suggesting lamotrigine is not a clinically effective treatment for people with BPD. A bigger disappointment. So drug industry is very shy of working in this area. They have retracted from initiating large-scale trials in recent years. Eli Lilly sponsored 2 large RCTs of dolanzapine, which included more than 300 participants, but did not result in drug approval for use in BPD. After that, no major industry funded research efforts, except the ones that I mentioned, and all of them are from the government. The question that we must ask ourselves in the Indian context is that does the lack of evidence hinder use of drugs? Answer is no. We are still promoting psychopharmacology. We are still talking about, and today we have a topic of psychopharmacology in BPD. Medication use being still off-label in BPD, drugs are nevertheless extensively prescribed to people with BPD. The lack of conclusive supporting evidence seems not to hinder the use of medication routine care. Bridler et al. Suggests that Cotypin has been found to be the single substance most often described to people with BPD at a time when not a single placebo-controlled RCT has been available that would have evaluated the effects of BPD at all, including the Black study, 2015. So, what is a wish list to narrow the gap between evidence and practice? There is no evidence, incidentally. Future trials. On the one hand, these should replicate previous research where positive findings were observed even in single small studies, for example, fluoxetine in the Simpson study. On the other hand, under-researched areas that need to be approached, medication use, especially SSRIs, is oftentimes justified by the prevalence of comorbid disorders, especially depression. But there is a clear lack of studies that focused on participants with distinct comorbidities. And that goes against the grain of using a drug in this fashion. In terms of intervention, we need more RCTs evaluating the highly used drugs like SSRIs and Cotypin. Fortunately, there are first new efforts from the industry to evaluate new substance explanatory trials, as I showed you. As long as there is no definite conclusion about any substance being effective, like you don't have imipramine as a gold standard or say clozapine like in psychosis, trials should include a placebo comparison group, like the FDA insists, of course. Future trials should include outcome assessment, should include BPD specific pathology, but also pathology related to comorbid conditions, especially if comorbid samples are in focus. Psychosocial functioning has been found to be crucial for judging mid and long-term effects and should also be assessed. Adverse events should be regularly monitored in a standardized way. Last observation period should last sufficiently long to reflect clinical practice and to allow for drawing conclusions of beneficial effects. Normally, in the case of BPD, it should be at least 36 weeks or so. I come to the penultimate part of my presentation with 2 epilogues. First is the problem with evidence-based medicine. So, as you saw, I have only presented evidence-based medicine for BPD. I have not talked about my experience with sodium valproate or with antipsychotics like say branancin or the risperidone. So I'll talk about the curious case of marine omega-3 fatty acids. So Karaziviska, 2021, a review collected 5 papers covering 4 randomized trials with a total of 137 patients. Result of that pooled analysis for BPD with omega-3 fatty acids, the effect size was 0.54, which is fairly good. It's a good clinical effect, that means. It includes separate examinations of 3 BPD symptom domains: the affective dysregulation, behavioral discontrol, and cognitive or perceptual symptoms, including things like dissociation and paranoid ideation. The effect on affective dysregulation domain was the highest with an effect size of 0.74. The issue is regarding right dose. This is very important because most of the omega 3 fatty acids available in the country do not have this combination. Previous meta-analysis have suggested that for major depression, a minimum 700 milligrams of EPA is necessary, and that is eicosapentonic acid and not DHA or docosahexaenoic acid, which does not seem to convey benefit. So, external disorder and depression and BPD, the problem is a combination of EPA and DHA. You require higher dose EPA. The general combination available in the market are only 300 milligrams of EPA. 3 of the 4 BPD studies reviewed here use 1000 milligrams of EPA or more. So 700 1000 milligram of EPA is the right dose, and this is something that you can cover in future trials in Indian context if the researchers are listening. So tentative summary is meta-analysis of marine omega-3 polyunsaturated fatty acids across 4 randomized trials and effect size of only 0.4 with 0.74 for effective dysregulation. So this is the kind of budding studies which have great potential in the international context for BPD. The last is an angst. So it's all very well to say use the DBT. I myself have some training in DBT and I'm using the DBT for the last 10 years. But in the Indian context, with shortage of trained DBT personnel and the reality that people are not trained in the DBT, our large pool of MA psychology is not trained, there is still hope by some common sense work which has happened, a MOBI study. So, effective alternatives to psychotherapy for borderline personality disorder. Monitoring outcomes of borderline personality disorder in the youth, a MOBI trial. The MOBI trial examined 3 treatment approaches: helping young people early, the mnemonic is HYPE. HYPE compared with weekly befriending, which is basically chatting on general stuff like movies and the weather, and a general youth mental health service or YMHS model combined with befriending. The study based in the UK. A key element of helping young people early is cognitive analytical therapy, a psychotherapy program focused on understanding problematic self-management and interpersonal patterns. The model also includes clinical case management such as attending to housing, vocational education issues, other mental needs and physical health needs. This is in the context of the National Health Service, so it has a UK bearing. But the important aspect is something else. The conclusion is that if you do not have personnel to treat with DBT, a good psychiatric management, especially if you can diagnose them early, can give good results. The primary endpoint in this study, a small sample size, was psychosocial functioning as measured by the inventory for interpersonal problems, circumflex version, and the social adjustment scale self-report. Secondary outcomes were suicidal behavior, etc. All groups improved significantly on the primary endpoint. The study was by Andrew Channon, published this year. The results suggest early diagnosis and not a very complete treatment drastically improve the lives of these young people. So the important aspect, the study is I think based in Australia here. So the basic idea is you catch them young and treat them in a proper good psychiatric management which is familiar to all of us, you get good results. I thank you very much.
Sir, you're on mute.
Thank you. Thank you, Dr. Nagpal. I can't think of a more clear and more concise, unbiased presentation on the current pharmacotherapy techniques that we practice and what evidence-based practice we should do. All of us know that off-the-label and other kind of prescription patterns and preferences are common amongst us in all kinds of practice, whether it is institutional or private practice. As long as it is effective or seems to be effective, we tend to use it, and by word of mouth it spreads. Thank you, Dr. Nagpal. We will now invite questions for both Dr. Bamrah and Dr. Nagpal. Can people uh, put it on the chat, or Avinash, are you there? Dr. Avinash?
Yes, sir. Yes, sir, I'm here.
Yeah. Can you coordinate the question, please?
Yeah. I'm just.
How many?
I'm just.
I assume there will be some.
Sir, as of now, there are no questions in chat. We
Right.
can people to ask questions.
Right.
Role of, so there's a question, role of lithium in the management of borderline personality.
No evidence.
Okay, there's no evidence for lithium.
The only evidence for the mood stabilizer is only for lamotrigine, one Crawford study, 2014-2018. See, you are having evidences for the domains. You're not having it for BPD. And I'm not discussing what the constructivity of BPD. I'm not going into that at all. But whatever it is worth, that is a topic and we stick to that.
Right. No, what
One small thing. There is some good animal studies to suggest that suicidal behavior you can alter by using lithium for BPD. One or two small case studies are available. But this is also anecdotal only. It's level 5 evidence.
So someone has asked, what is your view on the use of carbamazepine or oxcarbazepine in patients with BPD?
Your guess is as good
your
as
personal opinion. They want your personal opinion.
I don't use carbamazepine, and so I have no personal opinion. But your guess is as good as mine. With no evidence, it's a level playing field. Everybody can do what he likes. I have no comments to offer there.
But
well, that was very comprehensive. I enjoyed your talk very much. Yeah.
Thank you, sir.
You know, what I do, this is the problem, isn't it, Rajesh? That I think partly we've failed and our researchers have failed because, as Dr. Mittal was saying, the most prominent people who present who are, as he said, a burden on the services are people with borderline personalities. They'll cut their wrists. Well, the system in the NHS is free of charge. People just turn up. So they'll cut their wrists, they'll go home. The next day they'll come back again because they've unpicked the stitches, surgically unpicked the stitches so that they can bleed. And they're looking at that and they're looking at the doctor and saying, what are you going to do about it? So, this borderline personality is a real challenge. My understanding of the literature on pharmacological treatment of which there is not conclusive evidence, is all the evidence is you treat the symptoms. So if the patient has some impulsivity, anger issues, you might give them an antipsychotic, which might reduce that. If they present with some manic symptoms, you treat those manic symptoms. And if they come with depression, which they commonly do, then you treat the depression. It's all empirical until such a time as we come and find a magic cure.
There's another question for both Dr. Bamrah and Dr. Nagpal, that we are seeing nowadays more and more adolescents between the age of 15 and 18 who present with symptoms which are highly suggestive of borderline personality in genesis, or at least, suggestive of more or less full-blown borderline personality. But of course, our criteria says that we wait till the age of 18 to diagnose them. Do you think, we should start treatment approaches as we would for borderline, even in a 16 or a 17-year-old? And diagnosis-wise, do you think 2 years is going to make any difference?
So I told you about the MOBI trial, isn't it? MOBI trial is between 15 and 25 years age group. So basically, we are saying we need to catch them young. 18 years, there's nothing sacrosanct about 18 years. Whole idea is you're able to diagnose it, start good psychiatric management, start befriending them, start treating them like good case studies, spending time with them. That itself will give you good benefit if you do not have access to the DBTs. Because in the Indian context, you'll have about, in a metro city, 3 or 4 people who are good with DBT. In a tier 2 city, maybe 1, and after that it's absent. I have some experience because we run rehab homes, so I have some experience about the person available for treating DBT. That's where it stops generally. Minus the institutes, of course, which will have some training centers.
Dr. Bamrah, your opinion on that?
Yes, I'm very much with Rajesh on this. I think you have to go with what the presentation is like. If a young person who's 16 or 17 presenting with depressive symptoms, self-harm, very angry, very agitated, can't sleep at night, whether you're 40 or 16, in that sense, you just have to be much more careful in how you monitor them. The way we do it in the NHS would be that we provide them with support, psychological support, first of all. But not every place, even in the NHS, we don't, and not every place has the luxury of offering DBT and other psychotherapies. So quite often people will end up, if they're depressed and suicidal, they will end up taking medication, which is very closely monitored.
Dr. Bamrah, one more question, since you mentioned on the diagnostic conundrum, the fact that borderline personality disorder and antisocial personality disorder often overlap and go hand in hand. Do you think that we inherently as psychiatrists have a bias to diagnose more female patients as borderline personality disorder and more male patients as antisocial?
Yes, I think that's true, isn't it? And research does bear some of that out, particularly with histrionicity and borderline, that if you're a bit acting out and you're female, you're likely to be borderline, histrionic personality disorder or borderline personality. But if you've acted out and shown a little bit more anger because you've damaged a car, you're likely to be diagnosed with antisocial personality. I think if we apply the Dsm-5 or the ICD-11 criteria, then we would be more inclined to do justification to the genders as well. There's a bit of gender bias going on.
Right. Well, sir, I don't think there are any more questions. So comments from Dr. Mittal, and then we can move to the next session.
I must thank both of you for a very erudite, very clear, very concise, and very scientific presentation. But as Dr. Nagpal ended on a very pessimistic note, that there is nothing that we have evidence about, and there is no actual things that we can say works. So let us look at the non-pharmacological, or what we call non-pharmacological, but the therapeutic techniques employed by many organizations and, as Dr. Rajesh said, counselors and therapists in dealing with this condition. Can we now would Dr. Avinash introduce his colleague who is going to join him for the next?
Yes. Initially, we were to have Mrs. Arti Malhotra join us to give her talk on psychotherapeutic aspects of borderline, but she's been unwell. So I've had to request Miss Nyana Sabharwal, who is of course, a counseling psychologist. At the same time, she is one of the few trained experts we have psychology-wise in suicidology, and she's also she runs suicide prevention training workshops, suicide gatekeeper training workshops, and apart from that, she's also she has an organization called Safe Spaces that runs these workshops. We have done a number of workshops with Bombay Psychiatric Society and the Indian Association of Private Psychiatry in the last year, which have been attended with certification from a British group. And we also have, she's also been working towards having a suicide-free society. And that's her work in the area. Is Nyana here?
Yes, sir.
Yes. Okay. So this is going to be more of a discussion between Nyana and myself, and then we will take questions if there are from the audience. As a therapist, my first question to you is that, Mittal sir, you'll have to mute your. Yeah. My first question to you is that very often everyone dreads therapy when it comes to patients with borderline personality disorder. So the first question is, does a psychotherapeutic approach work in patients with borderline personality? That's the first question. And what has been your experience in that area?
So patients, yeah, like you rightly said, there is dread when we see or receive a patient or a client with borderline personality, because it comes with a range of emotions, things that we need to take care of in the interpersonal relationship space between the client and the therapist. Like any other personality condition, borderline being obviously one of the harder ones to work with, psychotherapy and pharmacology work together. But of course, as we have heard earlier, there isn't any golden rule where pharmacology is concerned, and nor is there with borderline personality per se. Of course, we've heard of DBT and other forms that we will talk about later maybe. But yes, there is a certain amount of symptomatic relief that can be provided to a client with borderline personality. Research has shown that, in 10 years, almost 90% can go into regression and live, healthy functioning lives. But of course, there are challenges along the way of staying in therapy, continuing with the same therapist, and all of those other challenges that come in the way of actually receiving those therapeutic outcomes that we're actually hoping for. So does it help? Yes, but there are of course challenges along the way that we need to, which come as a reality with the condition.
My second question to you is, there have been a large number of psychotherapeutic approaches which have been recommended for borderline personality disorder. Of course, dialectical behavior therapy being the most commonly used. There have been some who have recommended a cognitive behavior therapy approach. There are others who look at a more psychodynamic object relations approach. So, and then there are others who talk about a transference-focused psychotherapy approach. So, in your experience, I mean, well, we have people who are trained in either one of these who work with these patients.
Yeah.
So, and all of these have their own theoretical assumptions about borderline personality. So, what do you think is the approach that works best?
So, I mean, I cannot comment on some of the others that I am not necessarily trained or have a clear understanding on, but I can say that the ones that obviously research, but also what we've seen in our work with working with clients is, of course, DBT, because it has a multi-pronged approach. Whether it is in-person sessions, which are individual, whether it's giving them skill training, because that becomes a really big part of developing skills, placing a certain amount of responsibility on the client to actually take equal part in their own development, because you have to understand sometimes they come into the office hoping that there is going to be something that's going to change the experience completely without actually having to put in the work and the effort and maintain that level of contracting that otherwise with DBT that you put into place, for example. And also there's a lot more support work in person, in between sessions, keeping in touch with the client and ensuring that, how doing their check-ins and things like that. So overall, I feel personally that DBT has the highest level of impact on the client, and possibly after that it would be CBT and mentalization, which is another kind of a therapy that we're talking about in terms of allowing the client to actually understand it more cognitively, and then to possibly look at their outcomes from a more I am responsible to change the behavior, but actually having understood it completely from a mentalization perspective.
There have been a large number of therapists who I've spoken to, and they often talk about the whole issue of the love-hate relationship that the therapist-patient undergoes in borderline personality disorder, wherein one session you're hailed as the best therapist in the world, and one session, you're absolutely sort of brought down, which is part of their splitting, which does happen. But the key issue here is that, as a seasoned therapist that works with these patients, what is your advice with regard to, say, transference or counter-transference that develops? And what would be some of the ways you could suggest for younger therapists who are watching this show and even others to mitigate this when this happens?
So I genuinely feel that the relationship with Therapeutic Alliance is a very, very important part of receiving positive outcomes. And that includes the client feeling safe, the client feeling understood, the client feeling held, not having punitive responses, validating the client's not so much necessarily the behavior, but the reason for the behaviors, the experience of the emotion and what the client experiences. And when you're able to actually develop a very strong basis of a therapeutic alliance, which is trust, in that, of course, there's perceived rejection and abandonment that the client always has and holds on to. When you're able to navigate that with the client, that becomes a really, really important space. When a client splits, for example, and you become the worst, and there is, if they're able to come back knowing that I can still have a conversation, and this person who's sitting in front of me, my therapist, is willing to have that conversation, and I'm not going to be shut out or told go find someone else, or that there isn't that level of a negative transference that I will experience with the client, which of course, being human, it is possible, but we need to be aware of what we are experiencing and how we're conveying it, because the ultimate outcome is that we want the patient to get, or the client to get better. And they will do so if they get consistent space, because the big thing is that then I will quit therapy and I'll go somewhere else. And this happens a lot. So rupture and repair is something that I say that, is something that we need to build as therapists, a sense of, looking within, asking, am I feeling negative transference towards my client right now? What do I need to do about it? Sometimes it's good to have that conversation. Sometimes you may not want to have that conversation depending upon the relationship. But what I have noticed is sometimes there is that distance that I don't want to deal with this, and I don't want, but actually having that open door to say, let's talk about it, what happened, I understand. And then obviously creating boundaries and going over do's and don'ts of behavior. Hey, next time, let's find a different way to convey this. And I have seen that over time, these conversations, depending on the therapeutic alliance, does have, sort of reduced sort of splitting on the therapist as well. But also, I've noticed, at least with some of our clients, is that we're able to have that honest conversation. What was this about? Were you trying to prove something, for example? Was there manipulation underneath it? And there is an honest conversation that's possible. That takes a lot of work on the therapeutic alliance itself. The concern I have with the rupture and repair is there is a relapse that occurs, or suicidality that may increase when there is a breakdown with your primary therapist, or and that is something that we need to reconcile, that even if that is a ruptured situation, the person's moving on, it does so with having had conversations, knowing that it isn't about abandonment and rejection, and how can we help you find possibly another therapist that might be more suited for you, and knowing that you may not be in that place to provide that for them. So that's
there are 2 or 3 questions from the audience which I'll take up. One is that a lot of patients with borderline personality disorder are very manipulative. So any techniques on how to deal with the manipulation once you discover that there's a lot of manipulation happening?
So one of the things would be, again, to how you approach it, and when you approach it is an important aspect. But when you feel that the person is more open to have a conversation around, this was something, did that happen? How did it happen? I noticed that you said it differently last time. Can you help me understand this better? There are certain clients that I've had over the past year who today I can ask, was there a desire to manipulate in this? Was there a desire? And again, it's person to person. And again, the relationship that you share, where they are in their own journey of, the work that they have done, where are they on their affect regulation? How, are they in a place where currently there might be other life factors that are happening for them and may not be, but to identify and say, hey, I'm noticing these conflicting, can you help me figure it out? Without actually going and saying, hey, you're manipulating necessarily, because that again is defensive and goes in a direction that we don't actually want, because we want to open, clear, honest, transparent, a held, safe container for the client. It may not always be possible. Again, it is about prudence and using our best judgment on the client, because that's who we work with on as often as we do. But there is no, it's not a guarantee. There might be that there will be an outcome that we don't desire, but again, rupture and repair. So it is, taking that effort to actually able to do that each time.
Do you feel that patients with borderline personality disorder have a difficulty in recognizing their own emotions?
Labeling, if you mean, then yes. The fact that they are experiencing emotions, no. But I think that's a good skill that, we start off with, which is helping them label and recognizing, that my emotion is changing right now. When do I feel that? What might be the trigger? How do I identify that? But yes, labeling of the emotion, yes, they do have a difficulty identifying that for sure.
What is your take on the use of mindfulness or Buddhism related techniques in patients with borderline?
So I find mindfulness really helps. Again, it depends. Sometimes you will find clients who will say, this has not worked, that has not worked, I've tried this won't work, that won't work. But to always come back to it as coping strategies in the time of the kind of needing to distract. For example, the DBT uses that a lot in terms of their approach and strategy to help a client work through that at that point of time. So yes, mindfulness works, but I don't think it's a one size fits all. So we'll have to see who takes it on and does it, and who may be resistant to that. And that's again an individual basis, but does it work and help? Yes, it does.
Right. Another very important aspect is particularly if you get a couple that comes to you and one partner is probably having borderline personality disorder. Now the whole issue here is that what advice would you give them as a couple? Because very often the marriage is going through a lot of stormy emotional interactions, and it's a disorder which is going to remain and therapy is going to take time. So what's your advice to couples generally in this situation?
So I think first would be to help them understand that this particular condition also is a double-edged sword, because it seems to get most triggered in interpersonal relationships. And it comes around with the perceived abandonment and perceived rejection, which is possible to get triggered a lot more in marital relationships, of course. To help the spouse be psychoeducated on BPD itself. And therefore to be in continuous counseling so that there is a third person who can navigate that relationship until they've got the skill to able to do that. To also help the spouse understand the condition to the extent that it is not personal. There will be splitting. You might become the person who's both the loved and the hated person in the relationship, and what they could do in terms of managing when the emotions are really high, especially with self-harm and suicidality. How do I work with my partner when she does talk about or he does talk about self-harm and suicidality? And when that becomes then the focus, what do I do? We recommend today families and family members and couple to recognize and how to do first response. So for example, how would I know to have that conversation and not actually become overwhelmed, and what are the next steps I can do? Again, safety plan is something we do in therapy, and therefore involve the family in that as well, so that even the spouse knows how to manage and what to do in that situation, not to feel completely helpless. But yeah, those are some of the things that we would suggest.
Before we come to our last 2 or 3 questions, one very important question which is there is a lot of therapists, and I think young mental health professionals will come across a stage where they see a patient with borderline personality disorder, often attempt suicide, and some of them complete it. Now, the whole issue is that very often the patient is in therapy, and this may happen in between therapy sessions, or this might happen with the patient having not come to you for a month or so, and there's been some emotional events that have led to this. For a young therapist or a young mental health professional or a young psychiatrist who experiences death of a patient, particularly through suicide, I'm talking more about the borderline personality group. What would you like to sort of, advise such young therapists? What could they do to sort of, come to terms with this whole event?
So I think given the work that we do, I think it is always a possibility that we may be faced with this unfortunate outcome, and that holds very heavy on each one of us if we ever do face that. So the first thing would be to recognize that it is a possible outcome, and that one of the things that we can do is to obviously get the adequate support and help that we need to actually recognize what we could have done. It was the best that we have done. What happens in between sessions is, or there is a change in the client's suicidality, or a change is, if we weren't aware of it, there is very little that one can do. And that is getting that kind of emotional support during that time would be very, very important, because that can hang really heavy, and that can actually get in the way of you actually being present and a therapist going forward that would actually learn from this experience, and actually able to create certain strategies for oneself to able to manage the loss of that kind. Having said that, it is, I think the more support and emotional check-ins you do, maybe speak to someone, your own therapist, or join and reach out to other people who may have experienced this, to recognize that this is a possible outcome with BPD specifically, while there might be a fatal self-harm or might end in suicidality, and that is true for the illness. No matter what we may do in that situation, that is a possible outcome.
Okay. My last question to you is that, is there any specific strategy that can be used to ameliorate the emotional distress that we often see in patients with, particularly when they have those huge emotional outbursts? Are there any techniques that you could suggest that a therapist could, give their patient?
Okay. So I would recommend that we have a bag of resources that we can provide the client at that point of time that actually works, and use it with them in the session for them to understand how to use it outside of the session, because that becomes really, really important, that I know how to do it. So of course, mindfulness strategies is one of them for sure. But most important, I think, is labeling the emotion. I think most of the time there is an overwhelm of, I don't know what I'm feeling, I'm numb, or and that's where it leads to the self-harm behavior. So actually helping the client recognize their behaviors, they label their emotions. That's the first one of the really important things that I think really help. The second strategy that we suggest a lot is to work with, sort of changing and distracting from what you're doing to actually change away from the thought that is. So thought changing, working with the client to work on those, understanding their triggers. When you're experiencing that, what do you need to do? Who can you contact? What can you do? Who can actually help you during those times? Asking the client themselves if they have worked with certain things that would help them specifically, because sometimes not everything that works for one person may work for another. And over the years, your client would have found out things that actually work for them, and, kind of fall back on. That's another. The other one is, working with the client to sort of walk away from getting into sort of outbursts, and sort of recognizing that I'm going to do that. What can I do right now? So there are different strategies for that are there. With different clients work differently, but I know that mindfulness is one of them. We ask them to journal a lot. We ask them to, once they do that, it actually releases the emotion, so it kind of helps them come to a place where there is a certain amount of emotional regulation. And also then reaching out to people that they feel would actually able to patiently listen into whatever distress that they are feeling at that point of time without it being punitive or, oh my God, again, or any of those sort of behaviors that otherwise can bring the person to feel more perceived, triggers that are already available to them at that point of time.
Well, I think that brings us to the end. Yes, sir. Yes, sir.
I need to ask a few questions.
Yes. Okay. No problem.
Right.
Hello, sir.
Welcome, Nyana.
Thank you, sir.
Nyana, I just wondering what would be the role? You've been talking of single group, single person therapy and dealing with people on a one-to-one basis. Sometimes we don't have that luxury being able to deal with people on a one-to-one. So I was just wondering, would there be something you have been running support groups and group therapy sessions for people? So could you tell us something about three things specifically? One, about, you talked about this, Avinash introduced you as running this gateway, gatekeepers to suicide or gatekeepers to self-harm. That was one. And what kind of support groups, what kind of help do the support groups provide? How do they work in your experience, especially in patients with impulse control or people with triggers? And if you could elaborate a little.
Yes, sir. So in terms of first response and gatekeeper training, so that's something we work with families.
Nyana, can you unmute, please?
Yeah. So apart from, so let me begin with the suicide first responder, self-harm first response training that we provide, which is to actually intervene or help a person who's experiencing that level of distress, whether it's thoughts of suicide or self-harm. How do you intervene and bring them to safety? And that is a certain sort of 3-step program and a skill that we develop, because when that a person does come to you with that information, or when you are as a loved one in a family is talking or doing suiciding or self-harming behaviors, how do I respond and react in a way that actually can bring them to a stable sense of, I don't need to do this behavior right now, and there are other ways that I can get the help that I need. And so working within families to able to do that, or how do I help my young child, or how do I help my spouse in that moment to have that conversation, and sort of to work with their emotions, is something that the first responder training does. We have found that, of course, it helps a lot with suicidality and self-harming behavior. Sometimes even post the behavior of self-harm, actually having the ability to hold the person, get them the help that they need, understand what could I have done next, or previously, could you create a way to have them come and speak to you prior, and then kind of engaging them in a way to kind of be that person's support mechanism, which may not always be available in families. So that's what the first responder training program actually does. In terms of support groups, we started support groups for clients with borderline personality. And what began was a community of people who recognized that, they are not alone, and that there is this commonality between the way the personality disorder shows up. And they talk about sort of what happened during that time. It's just general sharing of what happened, what were their triggers, who did they reach out to, what did they do to help them get better, or they, since there are people on that group who are first responders as well, they were able to reach out to them to get the help during the time that they were, extremely distressed. What we did find over time is that rather than just being only a talk therapy book, in introducing skills that we would otherwise learn in DBT, for example, affect regulation skills or emotional distress skills, or Even mindfulness skills and strategies was something that were important to inculcate in these support groups for it to be something that you take away. And I know that I can, do these different things when I need, and I know that there is a place I can come to. I know there are people that I can reach out to. Of course, the message is please contact your mental health professional, keep them in the loop. Have you reached out to them? So that is something when, when they reach out and they feel unsafe, or if they're at a place where they want to do the behavior, that is something that the first responder is able to then speak to them, and people in the group are able to provide them with that security and safety. But we were meeting once a month, which kind of also gave them a sense of consistency that these are people I'm going to see. There's a recognition that they're going to be there, and there are people who are going to actually recognize and understand the experience itself. So you're on mute. So you're on mute.
Have you finished? I'm sorry if I'm interrupting.
No, sir. Please go ahead.
No. So my thing was that you are one and you are running a support group. Once you set up a support group, how does it perpetuate itself? How does it run itself? Is there any way that you can develop? Does it normally run, or does it die out after a few months, or does it stop? Or you keep adding new members to it?
Yeah, we kept adding new members throughout the year. But of course, being one thing is the consistency of it, including the person who's running the support group. Because then there is a sense of consistency. So you're on mute.
I said, how many groups can one person run? Would you think it would be good to plan how you run a group, set it going, and then slowly you allow the group to, operate itself? I mean, how it happens abroad in some of the places where the support groups actually run themselves. You think? Because here you are running the group. How many groups can you run after some time?
Yeah. So far, my experience is that we weren't in a place to able to transfer the group onto the group itself. Having someone there as a mental health professional or somebody as a first responder who could manage the safety of the group was very, very important, because there were triggers, there were all of those sort of things that had to be managed. So in my personal experience, so we weren't in a position to able to have it self-sustaining and running by itself. I think the presence of a mental health professional was important. How many can one person run? I don't think more than, honestly, 2 groups a month. And possibly having maybe 2 people on the group where you alternate could be something that is more sustainable over time. But I didn't in the year that we ran it, did we feel that it was ready to be handed over. And to be honest, I don't think it came with that idea of making it self-sustainable. So maybe if we go in with that idea to something to kind of think about, but we weren't able to see that level of consistency of to run that on its own.
So you're on mute. Anukansa, you're on mute.
Last question that I want to ask you is, how well do you think that is safety group, safe spaces group work, the training? How well does it work? Have you had any feedback of that?
So we have trained so far over 60 psychiatrists in the first response, and of course, other psychologists, teachers, family members. And we have found that the response is that it has impacted and improved the way they're able to relate with and work around with clients with suicidality. Just even making sure that, the question is asked at every, sort of from moving away from risk assessment to risk mitigation, safety planning, and all of those factors that, is a conversation that began ensuring that, all clients had a safety plan available to them, sort of actionable sort of plans that families could take forward as well. Also within families, we have found that family members are able to better understand and accept what the person's going through, which fundamentally changed the relationships within families as well. Has there been a reduction in suicidality in that sense? We haven't really but we are understanding that at least it's helping people stay safe and stay alive, sort of bit by bit, step by step.
Excellent work. Thank you. And Priyanka, you can take over from me. I'm done. Avinash, Priyanka.
Thank you so much, everyone, for attending today's event. I would like to thank all the three speakers, especially Nyana, for taking up this end moment and answering all our questions. I would like to thank Dr. Mumrah, who's actually, spoken about borderline personality all the way from UK, clearing our concepts. Dr. Nagpal, who's actually taught a lot about pharmacotherapy. It is a very practical aspect for me. Also, as a psychiatrist, I've learned a lot today because we've been dealing with a lot of borderline patients, especially with the, I think, COVID pandemic. The number of borderline patients who are coming out are much more. So I would like to thank all the three speakers. I would like to thank Dr. Avinash D'Souza and Dr. Anukan Mittal for chairing and moderating the sessions. I'm thankful to Dr. Ajita Nayak, who's the MMC accredited inspector for today's evening program. Thank you everyone for today. We are winding up a bit early, but I think we've covered everything about borderline personality disorder today. And I'm sure all of us go with a message today. Thank you everyone for joining today evening. We have another program by BPS, which will be organized tomorrow in the evening, which is the Sleep Psychiatry Interface, which is a regular series which we have been doing. And this is the fourth of that. I have emailed everyone the link, and I've also WhatsApp on the groups. So I would request everyone to join that as well. Thank you everyone for coming. Thanks a lot, and have a pleasant evening and a good night. So you want to say anything, Dr. Avinash? Thank you, everyone.